Hi, my name is Rebecca Williams Karnesky, and I'm excited to talk with you today about our work using psychological safety as a framework for creating a positive learning environment. In particular, I'll be sharing with you an example of success from the surgery clerkship. My only disclosure is that this work was funded by departmental and institutional grants. By the end of this talk, you should be able to define psychological safety and describe its importance in the clinical learning environment. You should be able to describe 3 structural changes that can increase psychological safety in the learning environment, and you should also be able to describe 3 interpersonal interventions that can increase psychological safety in the learning environment. A growing body of research shows that positive learning and working environments in medicine benefit trainees of all levels in many ways, including having significant impacts on trainee well-being. A positive learning environment has been shown to increase knowledge acquisition, patient safety, improve the patient care experience, increase work engagement, improve provider satisfaction, and increase provider well-being. Unfortunately, the clinical learning environment is often suboptimal, and medical students report high rates of mistreatment, particularly during the surgical clerkship. Our institution was no exception, with the student-reported rates of mistreatment as defined by the Association of American Medical Colleges at or above the national average during the surgical clerkship. In order to address this, we used an appreciative inquiry paradigm with focus groups of medical students to understand ways that we could improve the learning environment at our institution. These are some examples of the statements from students when they were asked to describe their perfect learning environment. They told us things like outlining expectations clearly at the beginning of the rotation, having instructors that are excited to have students, getting regular, meaningful feedback, having opportunities to help the team, daily learning, opportunities to grow and be better, and being able to fail in a setting without fear of being demeaned. When we analyzed these comments, we realized that what students were really talking about was psychological safety. Psychological safety is a concept from the organizational research literature. It's a team-level phenomenon wherein the work environment provides a climate of interpersonal trust and mutual respect. This allows people to be comfortable being themselves and reduces interpersonal risk. By doing so, psychological safety enables learning behaviors such as seeking feedback, sharing information, asking for help, experimenting, and talking about errors, all without being viewed as incompetent. In short, psychological safety can be thought of as the freedom to be fallible with the support to succeed. What we also know from the organizational research literature is that psychological safety is influenced by both structural and interpersonal factors. Using this information, we return to our focus groups as a way to hear from students about their perceptions about how structural and interpersonal factors in the surgical clerkship influence their perceptions of psychological safety. Through facilitated discussion, students identified several structural factors that influence their perception of psychological safety on the surgical clerkship. They then suggested ideas for how they thought these factors could be improved. Some of the structural threats to psychological safety that students identified included role uncertainty, task uncertainty, and resource scarcity. Some of the solutions they suggested included clarifying student roles on the team, specifying tasks that students could do, and limiting the number of learners on each service. Students also identified several interpersonal factors that influenced their perceptions of psychological safety on the surgical clerkship, and suggested ideas for how they thought these factors could be improved. Some of the interpersonal factors that students identified as threatening psychological safety in the surgical learning environment included negative responses to acts of vulnerability and a lack of personal connection or familiarity with the team. Some of the solutions they suggested included faculty and resident openness to questions, disclosure of errors by senior members of the team, time to meet other team members in a low-stakes environment. Using this information, in continuous collaboration with our medical student focus groups, we were able to design both structural and interpersonal interventions to increase the psychological safety on our surgical clerkship. These interventions were implemented at the start of the 2018 academic year. The first structural intervention that we implemented was an annual Residents as Educators course for surgery residents. This was provided during protected education time. It was a mandatory session that was highly interactive and co-led by residents and faculty. It focused on skills that could be used during a busy clinical day and were low barriers to implementation. What we found from this course was that it helped residents to feel more confident as teachers, especially junior residents who were not yet very distant from medical students. The second intervention that we implemented was feedback training and practice. We provided separate sessions for both faculty and residents using a feedback with good judgment model. We also discussed the use of appreciative inquiry and perspective taking to understand the position of trainees. These sessions were also highly interactive, which focused largely on skills practice. During sessions, we also held question and answer periods to address common concerns and challenging situations. We offered an annual long session once during the year with mid-year refresher courses. Based on student feedback, we learned that they felt particularly intimidated by the operating room environment. In particular, they felt anxious around the surgical scrub technicians who were responsible for maintaining the sterility of the operating field. Students felt that a better understanding of how the scrub techs did their jobs and what they were concerned about would help them feel more comfortable in this situation. They also wanted to meet some of these individuals before they scrubbed into a case for the first time. Using this information, we reached out to our scrub technicians and found they were excited to be involved in education of the medical students. They helped us implement a scrub technician expectation workshop, and were excited to welcome students into the operating room in this environment. This intervention familiarized the students with the scrub technicians as individuals and with their goals as professionals. This intervention empowered students to ask more questions, and it also empowered the scrub technicians to take on a new role as teachers. Finally, we found that many times students felt they weren't getting regular feedback, but weren't sure how to advocate for their own learning. To address this, we developed a facilitated student goal-setting workshop. We implemented an exercise at the beginning of each clerkship to help empower students to take charge of their own feedback. We helped them develop SMART goals that were specific, measurable, achievable, realistic, and time-based that they wanted to achieve during their rotation. We had them write down these 3 goals on a 3x5 index card. Students were instructed to share this card with their teachers, both residents and faculty, on the rotation, and to ask for feedback on their progress. Faculty and residents were also informed that the students would have goal cards, and they were told to ask to see them in order to help guide their teaching. We found that this not only empowered students to ask for specific feedback, but it helped our faculty and residents know what to focus on for each individual student. In order to improve the interpersonal aspects of the surgical learning environment, we implemented an orientation to the surgical learning environment session. This was incorporated at the beginning of the rotation during the orientation period. During this time, we talked about members of the team and then in different environments that learning takes place in during the surgical clerkship. We also talked about ways that these learning environments might differ from what students had previously experienced in the lecture hall. For example, we talked about how learning in the clinic might be different from learning in the acute setting of the trauma bay, or from the intensely focused environment of the operating room. During our investigations, we also learned that students didn't have a good sense of what the roles and responsibilities of their fellow team members were prior to starting their rotation. To address this, we created a day in the life of a surgery resident session. This session was led by a surgical resident and described the daily responsibilities of surgical residents. This helped students to understand ways that they could be helpful, and it also helped them understand what the role of the resident was as both learner and teacher. Many medical students also said that this session helped them think about what it would be like to be a resident and helped them to develop compassion for their resident colleagues. Finally, our most enthusiastically embraced intervention was the informal resident-student meet and greet. This was a protected lunchtime event with food provided, during which medical students were able to meet with their teams in a very low-stakes environment. We provided icebreaker questions, but most residents and students were able to have spontaneous, natural conversations that helped enhance their relationships during the rotation. Though it's an imperfect measure, in order to understand how effective these interventions were, we compared our pre-intervention rates of medical student-reported mistreatment, as defined by the Association of American Medical Colleges, with our post-intervention rates of mistreatment, and tracked this data for an additional academic year. We found a significant decrease in medical student reports of both observed and experienced mistreatment, as well as an increase in student reports of exemplary behavior in the academic year after implementation of these interventions. These changes persisted into the subsequent academic year, supporting our findings that these types of interventions can lead to lasting change in the surgical learning environment. Of note, we also had a significant increase in the number of medical students applying for surgical residencies after the implementation of these interventions. In summary, psychological safety can be thought of as the freedom to be valuable with the support to succeed. Psychological safety is critically important as it engenders learning behaviors. Fortunately, psychological safety in the clinical learning environment can be enhanced through structural and interpersonal interventions. I hope that some of these examples that we've shared will inspire you to try some of these interventions at your own institution. Finally, I want to leave you with this quote. Fundamentally, experiencing psychological safety at work means that you feel comfortable making yourself vulnerable in front of the people you see every day. And vulnerability for most people is absolutely terrifying. And I would add, also critical to learning. I look forward to your questions and comments.